Good afternoon, everyone. I'm Dr. Abinay, consultant physician working at Lakshmi Healthcare, Vanasthalipuram. Today, I'm going to talk about NSAIDs, which are non-steroidal anti-inflammatory drugs, and its effects on the GI tract, gastrointestinal tract. So, non-steroidal anti-inflammatory drugs are the commonly prescribed drugs in the day-to-day clinical practice. So, these are commonly available over-the-counter drugs. So, these are used worldwide as antipyretic, anti-inflammatory, and analgesic agents. NSAIDs are used commonly among the aged persons, like 65 years old patients. And these are used mainly for reducing the pain, swelling, any arthritis. But the doctor should weigh the risk-benefit ratio from the patient-to-patient scenario and use the lowest possible dose for the lowest possible time, which is the day's duration, to reduce the side effects on the GI tract. Usually, the side effects on GI tracts are usually gastritis, erosions, perforations, peptic ulcer disease, and GI bleed, which is very life-threatening. So, before we go into the further details, we have to understand the mechanism by which the NSAIDs work. So, NSAIDs have been shown to inhibit both isoforms of the COX enzyme, resulting in the reduced production of gastroproductive prostaglandins via the COX-1 pathway, and increased risk of gastrointestinal side effects are due to the decreased production of the prostaglandin. Now, this NSAID-induced toxicity, GI toxicity, is similar for both males and females, and therefore there is need for the development of gastroproductive NSAIDs that can be selectively inhibit the production of inflammatory products, prostaglandins, while sparing the COX-1 mediated production of productive prostaglandins. Such protective NSAIDs may provide an effective means of reducing the GI toxicity associated with NSAIDs and improving their overall safety profile, particularly in elderly population who are at risk for NSAID toxicity, GI toxicity. So there are various strategies which have been employed to develop alternate medications also, which are like nitric oxide, selective COX-2 inhibitors, and dual lipoxygenase. These approaches were aimed at reducing the adverse effects associated with the NSAIDs toxicity while maintaining the beneficial effects in the management of pain and inflammation. The development of these alternative medications has been driven by the need to improve patient outcomes and reduce the burden of the adverse events associated with the use of toxicity, NSAID toxicity. Selective COX-2 inhibitors are a subclass of NSAID that are designed to target the enzyme cyclooxygenase 2, which is responsible for the inflammation and pain. Unlike the traditional NSAIDs, which inhibit both COX-1 and COX-2, selective COX-2 inhibitors spare COX-1, which is important for the production of gastric mucosal prostaglandins that help maintaining the integrity of the stomach lining. In addition, modification of NSAIDs with nitric oxide donors has led to the development of nitric oxide containing NSAIDs, which have been found to be effective in the animal studies. The vasodilatory effects of NO lead to enhanced GI mucosal healing, which can be beneficial in preventing the GI side effect. Dual COX LOX inhibitors are another class of non-classical NSAIDs that have been shown to reduce the GI side effect. By inhibiting both lipoxygenase and cyclooxygenase, they can reduce the production of leukotrienes, which can cause adverse effects on GI side effect. This contrasts with traditional NSAIDs that only inhibit cyclooxygenase and thereby enhance the leukotriene production. So, as I've told earlier, that the mechanism of NSAIDs is to inhibit COX enzymes. Both isoforms of COX enzyme act on membrane phospholipid known as arachidonic acid to produce different prostaglandins that perform various physiological functions in the body. Phospholipid membrane is produced when produces the arachidonic acid, which in turn produces intermediate metabolites, prostaglandins, which again produces thromboxane 2, which helps in platelet aggregation, vasoconstriction. Then PGE2, D2 helps in sleep-wake cycle and pain. PGF2 alpha, reproduction and vasoconstriction. PGE2 is responsible for the GI production, regulates body temperature, renal hemostasis, inflammation, and pain. PGI2 helps in vasodilation, inhibits platelet aggregation, renal hemostasis, inflammation, and pain. So indications of NSAIDs, like I said earlier, it is used as an anti-analgesic, antipyretic, anti-inflammatory agents. There are available both over-counter and through medical prescription. Some are mostly commonly prescribed and utilized medications worldwide. So NSAID is used for pain in conditions like dysmenorrhea, arthritis, headaches, migraines. For acute mild to moderate pain, the first-line treatments acetaminophen and NSAIDs. Topical NSAIDs are recommended for non-low back musculoskeletal injuries. In cases of severe or refractory acute pain, medications that work on opioid and monoamine receptors, acetaminophen, opioid, or NSAID opioid combinations may be used. NSAIDs are not used for the management of neuropathic pain. Migraine and headache is another indication which is used for the pain. Among NSAIDs, there are ibuprofen, naproxen, acetylsalicylic acid, which is aspirin, and diclofenac, have been effective for abortive treatment of migraines, while tolfenic acid, piroxicam, and ketorolac may also be used. It has also been used for the dental pain. Ibuprofen and other NSAIDs are commonly used for other dental for acute and chronic dental orofacial pain. Ibuprofen is usually given in 400 mg dose twice or thrice a day, and liquid gel of ibuprofen is also available for faster and superior relief of post-surgical dental pain. Apart from that, NSAIDs are used in osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, bursitis, gouty arthritis, tendinitis, sinusitis, and other rheumatological diseases. While some NSAIDs like naproxen have been approved by the FDA for the treatment of inflammatory arthritis like rheumatoid arthritis and ankylosing spondylitis, they do not alter the disease course or prevent joint and soft tissue destruction that are common sequelae of this condition. So therefore, DMRDs like methotrexate are the first-line drugs for the inflammatory arthritis. NSAIDs have widely been used in the management of various respiratory infections like COVID-19, community-acquired pneumonia, and bacterial infections, flu. So refractory fevers sometimes subside with NSAID use along with macrolides and tetracyclines. So the effect of NSAIDs on gastrointestinal tract, like I said, are usually the peptic ulcer disease, gastritis, erosions, perforation, and GI bleed. So one should assess the risk-benefit ratio from patient to patient profile. It can also lead to intestinal obstructions. There are several risk factors that increase the risk of NSAIDs-induced GI tract side effects, including old age, comorbidities like cardiovascular renal disease, concomitant use of corticosteroid therapy, more than one NSAID, smoking, using larger doses of NSAIDs for a prolonged period is also one of the risk factors for the GI side effects. The use of gastroprotective slow-release preparations shifted the disease burden to lower GI tract and has set the way for several researchers to find the side effects of NSAIDs in small and large. NSAIDs cause symptoms like dyspepsia, gastroesophageal reflux, nausea, abdominal pain, which can be severe enough to cause bleeding, perforations, and gastritis. Dyspepsia, chronic, which is chronic indigestion, but presents as stomach fullness, bloating, and upper abdominal pain during or immediately following surgery. It is also the cause for premature discontinuation of the drug, apart from the symptoms. It can also cause esophagitis, which again present with dysphagia, odonophagia, or abdominal pain. Endoscopy showing damage to the mucosal lining, the esophagus, and pill components adherent to the esophageal lining confirms the diagnosis. People taking NSAIDs are more likely to experience gastroesophageal reflex, presenting with heartburn, cough, metallic taste to the mouth, and regurgitation. There are also effects on small intestine on prolonged usage of NSAID. So the inclusion criteria for NSAID-induced small intestinal injury include history of NSAID use, endoscopic findings of erosion, ulcer, or diaphragmatic stricture with non-specific tissue biopsy, improvement in signs and symptoms of the NSAID injury after the cessation of the so gastroprotective NSAIDs. There are some drugs which are gastroprotective, like COX-2 selective NSAIDs, NO-releasing NSAIDs, and dual COX blocks inhibiting drugs, which have similar therapeutic efficacy to traditional NSAIDs, but with lower risk of GSL. Selective COX-2 inhibitors are like etocoxib, paracoxib, they are commonly used in practice. So non-steroidal anti-inflammatory sites are widely used, as I said, in clinical practice, proven to be effective in treating pain, inflammation, fever. These drugs exert their pharmacological action by the COX enzyme, which are the right determining enzymes for the synthesis of prostaglandin and other prostanoids, such as thromboxane. Traditional NSAIDs inhibit both COX-1 and COX-2. COX-2 is primarily involved in prostaglandin-mediated pain and inflammation, whereas COX-1 is housekeeping role in productive gastric mucosa and blood. NSAIDs are commonly used for muscle management of muscle pain, spinaria, arthritic conditions, pyrexia, gout, migraines, and as fat-sparing agents in certain acute traumas. In addition to their anti-inflammatory, antibiotic properties, NSAIDs have been shown to offer protection against a range of critical disorders, including the cancer and heart attacks. Now, examples have said like diclofenac, ketorolac, phenobarbital, ibuprofen, and carbiprofen. NSAID enteropathy is a frequent and severe NSAID gastropathy. Recent advances in diagnostic devices have shed light on this issue. The most commonly affected areas are the distal small bowel, terminal ileum, ileocecal junction, and imaging studies have revealed erosions, bleeding, ulceration, stricture formation, and perforation. Anemia and hyperproteinemia are the most common clinical findings. NSAID coronopathy is being increasingly reported in the literature, but limited data are available compared to the NSAID gastropathy and enteropathy. The diagnosis of NSAID coronopathy can be challenging due to varied nature of the symptoms, which may resemble those of inflammatory bowel disease and malignancy. So finally, NSAIDs are frequently utilized due to their beneficial analgesic and anti-inflammatory effects. Nevertheless, their administration is associated with various gastrointestinal adverse effects, especially in high-risk individuals. Consequently, the healthcare professionals should be careful considering the risk and benefits of the NSAID therapy for each patient and explore the alternative treatment options. Furthermore, studies are needed to assess and compare the efficacy of gastroprotective NSAIDs with traditional NSAIDs. Overall, it is essential to achieve balance between the potential benefits and harms of the NSAID therapy. To optimize patient outcomes, one should take the NSAID with food and along with the H2 blocker, PPI blockers, and in the lowest possible dose for the lowest possible duration to decrease the side effects and increase the beneficial effect of the drug. I thank everyone for the patient listening. Thank you.